panel of today. It's my utmost pleasure to invite you to participate, and I think the three of you in the back, you should move up here so we have you a little closer if you want to. We say, friend, move up to a higher seat at the table instead of sitting too far away. Listen, in this last panel of today, we will focus on faith-based organizations in regards to global health and rebuilding after COVID-19. And we will also focus on the opportunities working with the Pandemic Fund under the World Bank that you will hear about a little later. We will run 2 rounds where we will have 3 opening launches in each of the 2 rounds. And then we will focus on 2 areas with also an opportunity to ask questions from the audience. To assist me in this conversation, I am both honored and privileged to introduce our 5 panelists. First, Mr. Deus Bazira, and you can raise up your hand so they know who you are, yes, who is the inaugural director of the Georgetown University Global Health Institute and engaged around the Georgetown Larsen Commission on Faith, Trust and Health. Then we have Mr. Douglas Fountain, and Douglas serves as the Executive Director of Christian Connection for International Health. We have thirdly Khushwant Singh, who is sitting closest to me here. He is Head of Secretariat at International Partnership on Religion and Development, also called PART. Then we have Peter Yeboah, who is the Executive Director of the Christian Health Association of Ghana. And finally, we have Jeffrey O'Malley, who is the Senior Advisor for the United Nations Development Program, UNDP, and based here in South Africa. Please give our panelists a warm round of applause. So in this first round, we focus on how to rebuild trust in public health systems. And each of our 3 discussion launches have 3 minutes each to address this topic. And I want to start with Deus Bazira. You have 3 minutes to open, and I press start over here on my clock now, so we keep a sharp eye on time. Deus, the floor is yours.
Yeah, thank you, Larsen. Good evening, everyone. Hopefully we'll get joined by others very soon. The issue of trust in our public health systems following COVID-19 pandemic is a no-brainer, because we all saw how the world that appeared very prepared to address any pandemic, all of a sudden things fell apart. And there was a disconnect between governments, between scientists, between healthcare providers, faith leaders, people in the community. And in some ways that impacted, in some parts of the world, some suboptimal responses to the pandemic. I think I'll restrict myself, given where we are today, to address the issue of rebuilding trust, within the faith context, and the role faith institutions, faith leaders, and faith communities can play in helping us do that. One is, Catherine and I always talk about this, there are about 81% of the world population subscribe to some sort of faith or religion. And so all our politicians, all our scientists, a lot of them are also faith people. And so if we really want to help rebuild the trust, we have a foundation that can help us break down barriers that we've seen in the pandemic response in the past. So I think where I see an opportunity is for us within especially the health science space, the public health space, in medicine, in public policy, integrating faith as one of the components we address when we are building responsiveness in our health systems to respond to any public health threat. So that we are not only calling on faith communities and faith leaders as instruments of change or as instruments we can rely on to tackle an existential threat during a crisis, but that rather we have built a partnership during times of stability, when there is no emergency, when there is no crisis, and we've defined the rules of engagement so that we are all working towards a common goal of the win-win situation here. And so I think we have an opportunity now, when there is some bit of stability in the public health space, for us to establish new partnerships and criteria for how the faith community can work with governments, but also with the science community to build effective, mutually beneficial partnerships. Thank you.
Perfect. Thank you so much. And then, Jeffrey, I will hand it over to you. Please, the floor is yours.
Sure. Thank you for the question, and good evening, everybody. Let me come from a different angle. We're meeting in South Africa this week, and most of you will know that Thabo Mbeki was the president here from 1999 to 2008, which were really the darkest days of the AIDS pandemic. And he was deeply skeptical of public health advice and of medicine. And most reliable estimates believe that because of that skepticism, around 350,000 South Africans died over that decade who didn't need to die, and hundreds of thousands more were infected with HIV, who didn't need to be infected with HIV. But the Treatment Action Campaign, which actually started here in Cape Town, mobilized civil society, used the courts, challenged Mbeki, and when HIV treatment was finally made available and rolled out here in South Africa, there was a huge demand from the public and dramatic uptake of that treatment. So why am I starting with that anecdote? You asked me about COVID. It's just to say that skepticism of public health isn't new. It didn't come with COVID. And it's not something that only comes from the uneducated or the grassroots. It can come from the president of one of the most successful countries in Africa. And that skepticism has been, it can be deadly. Hundreds of thousands of people can die from such skepticism. But here in here in South Africa, once HIV treatment was available, as I said, there ended up being much more public trust in public health than there was public trust in the government. So I think we're sometimes dealing with two different kinds of skepticism. There can be skepticism of the government, skepticism of the state, and there can be skepticism of the high priests of public health and medicine. And sometimes they're in tension with each other, which was the case here during those dark days, but sometimes they reinforce each other. And I think what happened during COVID was that we had skepticism of the government, and we also had skepticism of public health and medicine, which of course was a problem. So what can we do to rebuild trust? As much as there's been a lot of research on what drives vaccine hesitancy or non-adherence to TB treatment or whatever, there's much less operations research on what reliably builds trust. What challenges it? How do we challenge misinformation? How do we encourage adherence to sound health advice? And my own gut instinct is that part of the answer is that before we ask people to trust the government or to trust public health experts, we need to ask government officials and health experts to have more trust in the opposite direction, to have more trust and respect for the public. When people feel they're being patronized, when they feel they're being talked down to, when they're not being respected, they're not going to listen to what they're being told. Some of the most effective public health messaging around COVID emphasized what governments and experts did not know. I was living here in South Africa. We were told not to walk on the beach. Many of us, whatever our background was, we kind of knew, well, why shouldn't, isn't walking on the beach one of the safest things we could possibly do? But it was said too definitively. I think when you look at where governments were effective in working with their public about COVID, it's when they said, well, we don't know, but this is what we think. We think this is risky, but we're not sure, and as we get updated, we'll tell you more. And I think that being honest and being respectful and being willing to talk about what we don't know as well as we know is a huge part of building trust.
Great, thank you so much. And then we will finalize the first discussion launches with you, Khushwant Singh. The floor is yours.
Yeah, thank you so much, Esben. Thank you so much. Just let me give you concrete examples from our partners within the context of the International Partnership on Religion and Sustainable Development. And I learned from the COVID pandemic and the contributions of religious actors that even those governmental actors which were deeply kind of critical of religious actors per se, that they understood for the first time that religious actors are important and that they really contribute to solving problems. Just give you a few examples from members. For instance, priests, monks, religious leaders from various religions contributed to overcome vaccination hesitancy, but they also used divine scriptures to counter fake news. For instance, where traditional and religious leaders use scriptures to say that this is the work of the devil, so you better stay away from vaccinations. So they used religious scriptures to really develop a counter-narrative to make sure that people who do not want to get a vaccination got a vaccination. But another thing which I think is very close to religion is spiritual care. They used WhatsApp messages, for instance, or online consultations to provide spiritual care for people who were already affected or, as you said, could not even go to the church, the mosque, or to the temple because it was simply not allowed. It was simply said, it's closed and you're not allowed to go to. So people who felt very isolated still could make use of services that were simply provided digitally. The other thing, what I think was very impressive is that religious actors provided very practical support. For instance, we know of cases where they chartered flights from the UK to go to India and Bangladesh and other places to bring over oxygen, also to remote areas. So actually, they were filling the gap of not existent services which should actually be provided by the state. And of course, there are people who criticize this concept and saying, yeah, but religious actors should not fill the gap of what the government should do, but like, how can you blame someone if he's or she's doing a good job? And interestingly, religious actors really transcended religious boundaries. They did not say, oh, okay, you are a Christian and that's why I'm giving you oxygen. They just provided the help where it was needed the most. So just a few examples to see that if you use a very convincing evidence-based narrative, you can even convince people who are deeply, deeply skeptical towards religious actors in positions of decision-making. Thank you.
Great, thank you so much. I want to start out with something you said, Deus, in around the 81% that relates to faith, and that's a constituency that is also relevant for politicians. Some of the things we have heard today here, also here in South Africa, is that they are actually not viewed as very relevant. So how, for the government, so how do we, with the teachings of, or the experiences from COVID-19, how do we prepare with the faith-based organizations to be more relevant in the future if a new pandemic, for example, hits us? And maybe start with you, Deus, and then I will open up for the rest of you.
Thank you. Let me just step back a little bit. Last week, I was in Accra, Ghana, at a summit hosted by the President of Ghana on Africa Health Sovereignty. And then I went to Malanga in Durban towards the end of last week to meet with African Union leaders and business leaders to talk about wealth creation through health. In those two conversations, one thing I noticed that we started off every single meeting with a prayer. And we brought all sorts of religious leaders to bless the summit and to bless the meetings. For those of us who work in the global health space, every time you visit a country, I'm sure you've seen this, and you're meeting with government officials, they always start off with a prayer. So to me, what that communicates is that faith is part of everyday life for a lot of people, politicians, business people, faith leaders, common people on the street. I think the challenge has been that we've not centered faith in a lot of the other things we do outside of our individual perspectives about our relationship with God or with our institution. We think my job is to go to church or go to the mosque on a Friday or a Sunday, but when I go to the office on Monday, I'm a whole different person. I act differently. So I think what we need to do is to try as much as possible to center people's faith in some of these everyday decisions they make, including policy and science decisions. We know that science and even public health and medicine, we talk a lot about people-centered approaches to doing things. But when we talk about people-centered approach, where do we actually find those people? There are certain structures that help us reach the people. The faith communities is one of the easiest ones. That's a touch point we could go. If you look at civil society, community-based groups, that's also another touch point we could go. So I think if we were more structured on how we take advantage and leverage some of these touch points, and in this particular case, the faith communities, to include them. For example, in the research and development cycle, even before we have come up with a vaccine, we've included them in the journey so they understand the decisions that we make along the way. They may not be the ones doing the bench science, but they understand what it means to get people as subjects involved in a research study. That they understand all the protections that have been built in to ensure the safety and efficacy of the new discovery that is being worked on. So by the time you come with a final product into the market, you have a vaccine now you want to promote, you already have a lot of messengers who are going to help spread the message over how this came about and why some of the misconceptions are not actually true. And then finally, when you have a public health message or you have a product you are launching that could help cure a new disease, you also think of who do you use as the trusted voice that will speak on your behalf. The best scientist who comes up with a discovery is not necessarily the best messenger when speaking to the people in the rural area. Who do they trust? They trust their pastor, they trust their imam. So why not partner then with those trusted messengers and equip them with the right messages so they can become the vehicles of transformation and the vehicles of change? But it takes a bit of time to build that. You can't do it when there is a crisis. You can't do it when there is already a disease outbreak. And that's when you're trying to mobilize everyone. Yes, from the goodness of the faith community, people will show up. The faith leaders will show up like we saw in West Africa, Ebola, a network of religious leaders who came together to help in the fight against Ebola. But you can't always do this in a crisis mode. At some point, you're also going to have some negative forces playing. And then your religious communities and religious leaders also take on the other side. And then you run into trouble if the faith leaders are the ones that are promoting conspiracies and negative messages because they are trusted by their people. Those negative messages might actually take deeper root than your public health leaders or medical experts. So for me, I go back to the basics that we need to have a transparent, mutually beneficial, and respectable partnership during the times of stability and not wait during a crisis in order to, because they can tell that you're just trying to use them. Thank you.
Thank you. Anyone else on that particular matter? Yes? Yeah?
Yes, many thanks. Let me give practical experiences of the role of faith, the faith actors at the peak and dawn of the COVID-19 pandemic and see how we can situate what my brother just said. In Ghana, at the dawn of COVID, we had two key challenges. One was that we realized how fragile and vulnerable our health system was. Our health system had been structured to only treat diseases, sick care model, and not public health. So there were gaps in the way we could respond to this pandemic, number one. Number two was that the political leadership at that point in time realized that they had no experience or expertise in handling a disease of such magnitude. And also, they also lack trust. They had just won an election. The system was polarized. So in terms of capacity to mobilize the key actors, they had that. And this is what they did. The first thing they did was mobilize all the Christian religious leaders. By the way, Ghana, 71% of Ghanaians identify as Christians, 15% Muslims. And there was prayer session at the presidency against COVID. It was a clear combination of science versus religion coming together. Now, this is what the religious leaders had: the assets, the infrastructures, and leverages. They had trust, which is the biggest social capital. Trust, by the way, must be earned. You can't confer trust. And they had access to 4 social spaces: education space. Most of the best schools in Ghana were by the religious leaders, early missionaries. The health space, and of course, and also the church space, the power of the pulpit, the unquestioned authority of the clergy, and interfaith platform. So they could mobilize the community. And this is what the faith leaders did. They promoted vaccine uptake. They modeled compliance with COVID-19 protocols. And they also countered disinformation and misinformation about COVID. And they were the frontline messengers because they were that credible. At that point in time, the opposition had also set up a parallel COVID-19 system. So the faith leaders had that stability, respect, the cloud, the gravitas to really say the message. So that was the first thing we did. And about 40% healthcare services are provided by faith-based healthcare facilities. And this is what we also did. CHAG was actively involved in risk communication, surveillance, contact tracing, and case management and everything. And combination of all this ensured that indeed that trust had to be earned, the people trusted, and that constant community engagement and respect for faith-based actors and the evidence of their past record, as my brother was saying, because all the missionary schools and the rest had produced the type of political leaders we had. So in our part of the world, faith-based leadership was very instrumental in the management of COVID-19 pandemic. And faith-based health facilities were trusted arenas because they were seen as strategic allies, hubs of innovation. And in Ghana, we have one of the best social health insurance system in Africa. This was pioneered and piloted by CHAG and acted as proof of concept and nationalized later to what we have as a national health insurance scheme. So per these records and also the deep community engagement and trust, definitely faith became an instrumental asset in the control management of the pandemic. And as we begin to restructure our health system to be resilient, the role, the responsibility, and relevance of faith-based actors as partners that will complement government leadership has proven to be indispensable, despite its minuses. So trust was earned, and trust is credible, and trust should be the pathway of mobilizing and restructuring the entire health sector. Thanks.
Thank you so much, Peter. Very, very excellent examples. I wanted to ask one last question before we move over to the second round. And the question would be, if you were to design a bucket list of the most important initiatives one could take in regards to avoiding a new pandemic, in regards to restoring trust as well, what should be on a bucket list? Because I think we all expect that there will be a new pandemic. And to your point, Deus, around being prepared, what do we do? What should be on the bucket list? It could be items, it could also be organizations that should be part of it on a national level or on a regional level, since the pandemic knows no border.
I can go. Thanks for this, and appreciate the opportunity to speak to this. Maybe I'll comment here about the why, and then in my remarks in a few minutes, I'll talk about the how of faith-based engagement. Let's remember, as we spoke earlier today, about 84% of the world's population belong to a major religion. And we know that that's important for the following reasons: that religious actors have a tremendous impact on the values and the attitudes and the behaviors of people. If you don't value life, if you don't value the life of a mother or a child, then it's not going to do any good to run an immunization campaign. If you don't have the attitude that says that the immunization campaign can be helpful, then you're not going to have any success with your immunization campaign. So before you ever get to behavior, you have to influence values and attitudes. So now the religious leaders have a tremendous role to play in strengthening those values and undergirding those attitudes that are necessary for the health leaders to come in. So my bucket list thing is to have a unified voice for the religious leaders together with for the religious leaders and the health leaders to work off of the same page. That's really vital. I think one of the things that we discovered when we did research on vaccine hesitancy during COVID, we did a global benchmark study about that. And for the agency formerly known as USAID, God rest her soul, one of the big takeaways was that vaccine hesitancy was driven in large part by what we called proxy issues. The people either didn't trust government, or they didn't trust the corporations that were generating the vaccines, or they didn't trust the westernization of the interventions. So it was very difficult especially for many religious groups to be able to advocate for those, because they had those attitudes that limited their ability to get on board with that. You can't just fix that overnight. You have to build that in relationship over time and address and listen to what their concerns are and work with people to see what they're willing to do in terms of sharing a space, sharing a voice. So that's my bucket list.
Great. Yep, we can take all the way up here.
Yes, 2 points. During the peak of the COVID, we experienced vaccine nationalism. So one of the points that people advocated for in my country was to set up local production of vaccines. And now we have Vaccine Institute as a result of the COVID-19 that we experienced, so that at least we will not be vulnerable in the future. That said, one lesson to really that we did, that at the peak of the COVID, all the public health systems closed down because health workers were dying and the rest. And CHAG, we were also asked to do same. And we said, where are our values? The pro-life. This is a time for resilience, for endurance, for demonstration of compassion. We stayed. And so we realized that continuity of routine essential healthcare services were very vital, because during the COVID, we saw mothers dying, mothers who could not, some of the places where public health systems closed down. Some mothers died because they couldn't have life-saving cesarean section. Certain life-saving interventions were really shut down. But we were there. Some of our staff contracted COVID, they died. But then it demonstrated trust and confidence. Post-COVID, we could see surge in attendance within our facilities. Why? Because we demonstrated stability, predictability, that Christ-loving demonstration of that human pace, that human value was there. So these 2 points are very, very important. Self-reliance, dependability, and 2, continuity of routine essential healthcare service as the basis of rebuilding trust and confidence in the health system. That is our experience. Thanks.
Thanks. You invited a bucket list. Let me share 4 ideas, 3 of which really are just about health in general and not about the interaction with faith, but then a brief reflection on faith. So first, again, it's not a new idea, but taking a human rights-based approach to health is absolutely essential. And there are many dimensions to that. And we just heard about vaccine apartheid, but the first and most important dimension of that is that everyone has an equal right to health information, to health services, and everyone in the world, and everyone regardless of what community and what, frankly, faith leaders think of them or their behavior. Everyone has the right to health. And a corollary of that on the right to health is we have to convince governments not to abuse human rights and not to take advantage of pandemics to pursue counterproductive agendas. A particularly egregious example of this during COVID happened in Uganda, where The government of Uganda arrested a bunch of LGBTI people that were staying in a shelter in a relatively safe place, claimed that they were violating social distancing, and put them all in a crowded cell. It was an anti-LGBTI agenda. It wasn't a pro-public health agenda. And people also see through when a government is lying, frankly. Secondly, back to vaccine apartheid. We need to radically rethink intellectual property. We need to radically around things like, vaccines and medicines. We have to revisit what's called the Doha TRIPS agreement, for those of you who know it. Clearly, the current intellectual property regime isn't working. We had something called COVAX. We had an African equivalent of that. They didn't work. We have to admit they didn't work, and we need a much more instantaneous sharing, not only of products, but also of data about things like genomic data. This cannot be, owned by a university in Boston or a center in Geneva. Third, we have to think multi-sectorally. Of course, the health sector is absolutely crucial, especially for provision of care, diagnostics and treatment, and to a certain degree for provision of health information. But we all know that health is driven by nutrition, by social patterns, by inequalities. And also, we have to look at, when we talk about a sort of public health prescription, we can't look at its impact only in health terms. Shutting schools for 3 years may have slowed the spread of COVID, but it also set back a generation of children from their education. So we need to recognize that interventions in one sector have impacts in other sector. And also interventions outside the health sector can either promote or undermine health. So those were my 3 bucket lists from the health perspective. But just a last quick reflection on faith. We heard about faith leaders as health messengers already, and very much from Peter about faith leaders, faith-based organizations as providers of health information. But when people are dying, their faith and their faith community becomes even more important. And faith leaders and faith communities are witnesses to the impact of epidemics. And one of the things we saw with COVID, we saw with HIV, we see again and again, is there's even skepticism about whether these diseases exist. Yeah. And faith leaders and faith communities are often the people who really are at the front line of seeing the suffering and the death. And they have to facilitate the testimony of those people and allow people, who've been affected by these diseases to have a voice, because that's what makes it real. Thanks.
Thank you. Kushwan, did you have a comment?
Just a small point, because a couple of points that have been mentioned were also on my bucket list. But that's good. Just one point. It is with regards to the consultation process of governments when it comes to changing legislation, but also when it comes to setting up rules and regulations to kind of prevent the spreading of a pandemic. And the feeling which we had was that, of course, I'm speaking from specifically from a German perspective, but also listening to other part members, that governments tended to either be very science pro, so they just wanted to speak with the hardcore scientists from the field of pandemics and so on, but they wouldn't invite social scientists. Sometimes they did, but not so much. But civil society was not a key actor. So of course, one wish would be that they have a very inclusive approach before they're changing rules and regulations and legislation, and they make sure that also religious actors are regarded as an important pillar of civil society. And that, of course, is only possible if they are convinced that religious actors are able to really contribute. So all the good examples that you have been given, they need to be in the newspapers, they need to be in the knowledge centers and so on, so that it really kind of creates a coherency that is lacking at the moment. And I'm also very impressed what you have been telling about the experiences in your countries. So, I mean, we need this information. We need these good examples. Thank you.
Thank you. And Deus, did you have a final remark in this round?
Okay, yeah, so my bucket list will include we should domesticate, global health interventions or pandemic preparedness and response. I think we spend so much time at the global level, make all the decisions at the global level, but those things don't necessarily trickle down to the ground. The real impact is felt in people's lives at the community level. But when you look how we allocate resources between global, continental, national, and local resources, most resources tend to go up, but the real work gets done on the ground. And secondly, solidarity hasn't featured here that much. But to build solidarity, it should really start at the community level. We can't build global solidarity if people within a community, people within a region, within a country are not working towards the common goal. So we should spend more resources trying to build solidarity within countries, within communities. We connect them, community to region, to national, to regional bodies, and then continental before we go global. Because we are as strong as our weakest link, So if the national level coherence doesn't exist, it does not matter how many billions you may have mobilized at the global level. When push comes to shove, things will not happen. And then thirdly, it's high time, and there is now enough evidence, there's a lot of writing that has gone on, that faith or religion is a proven determinant of health. And therefore, we should start including that in our policy processes, in our planning, health policy planning, so that faith and religion are taken into consideration and are given the same level of attention like we do economics, we do education, as factors that really help determine our health. And so if I had a bucket list, I would like to see policies in countries that have integrated faith and religion as part of the determinant of health and coming up with specific interventions on how we do that. This is where, for example, spiritual care becomes an issue. How do you bring spiritual care to be part of the comprehensive healthcare delivery? At the moment, it is just left up to individuals. I will end by giving you a specific example. A long time I was working in Rwanda, and we found out that there were people dying in hospitals all by themselves because they had no relatives who could come and feed them. We did a mapping in that area of the country. There was a total of 1,000 churches and mosques combined that were not in any way connected to the hospitals. And so when we convened the religious leaders and we told them that there were people in hospitals who are not getting fed, who don't even have somebody that comes to visit them and talk to them. And they were like, we didn't know. Nobody from the hospital ever told us about this. And they organized themselves using their own resources to start providing not only spiritual care, but also social support, nutrition for the patients. And that partnership has continued over time. So I think we tend to fear, those of us who work in public health and policy and government, that when we're in these public places, we should leave our faith and our religion behind as if we can divorce ourselves from that. And I think when we do that, that's even when you end up with religious people who are in a government becoming corrupt. So on Sunday, they come to church and they contribute, they give these offerings, and then on Monday, they go and start stealing, because we've tended to separate these values from our work and our public persona. So that would be one of my bucket lists.
No, we will now move into the second round, where we will be a little more specific on the faith-based organizations and the role of them in the pandemic preparedness and also prevention. So we have now made a status on what has been happening around us. We have formed a bucket list. So what could be potential next steps? And I want to start with giving Douglas 3 minutes as an opening to the second round. Douglas, the floor is yours, and you will get a mic as well.
Okay. All right, thank you. I wanted Peter to go first because I wanted to hear what he said and then say ×2. So I think he's got very practical experience with that. So I mentioned that I was going to differentiate my previous comment with the why from what I'm going to say now about the how. But to do that, I want to hit a high concept note here, which is that we should rethink our approach on this from thinking about projects. How do we do projects to intervene or to strengthen health or something, but think about platforms instead. Platforms, not projects. I'm not the one who coined that. I think a number of people have written about platforms, not projects. But what we're talking about with faith-based organizations is a platform. It's a platform for change. And as you heard Archbishop Thabo this morning talk about changing the heart, how do you do that? You don't do that with projects. You do that over time through institutions. So what do we know about the institutions? We know some facts about faith-based institutions. Just in the Christian health landscape, we've been working on the Christian Health Asset Mapping Consortium. And just in 17 sub-Saharan Africa countries, we know that there are over 8,000 health assets. There's 4,000 in 11 countries in South and Southeast Asia. We know, for example, that there are 1,365 university-level health training institutions that call themselves Christian in the world. There's about 700 of them that are in low and middle-income countries. They run collectively 3,800 programs of health science training. So if you want to start changing things, let's get to the curricula. Let's get to those programs and start thinking about what that education and what that equipping starts to look like. But equipped with facts, you can start to then plot out what that movement, what that platform can actually do for you. Now, I want to take also a slightly controversial position on this. I think throughout this day, we've been talking about all of the benefits and all the great ways that faith-based organizations work. They are local. They are the community. We know that they can mobilize rapidly. We know that they can establish management systems quickly. We know that they have access to underserved areas. They leverage additional donors. We know that they're very good at knowledge generation and knowledge management. They might not think of it that way, but they're very good at communicating and passing along best practices within their networks. But here's the problem. Working with faith-based is also confusing. If you are a government or a private actor and you're trying to work with them, there's fragmentation. Which faith-based group are you going to work with? Are you going to work with the Catholics, the Muslims, the Protestants? Are you going to work with which group are you going to work with? There's no single one to coordinate with. There's uneven capacities. We have to think about that and think about how do we get everybody to a baseline on pandemic preparedness so that they can be ready to respond. There are transparency concerns. There's always transparency concerns. Donors are always worried if they put money into faith-based, will they get the data out that they're looking for? That's always a concern. I think there's also coordination challenges, and some of that is kind of a subtext to the above points. But you find when there are parallel coordination or parallel funding streams coming in for similar services, sometimes faith-based groups have a hard time differentiating that. So I think those are some challenges that we have to work through. So if we are honest about what faith-based groups can do, we have to also address those challenges along the way. Platform, not project.
Thank you so much. That was really very, very valuable. Then over to you, Peter. 3 minutes.
Yes, certainly there are prospects and potentials of faith-based health systems in there when it comes to pandemic prevention, preparedness, readiness, and the response actions. Very important. Let me put it this way. Faith-based health systems, to me, are very fundamental, instrumental in pandemic prevention, the experience we've had. And we should have deliberate or intentional investments in faith-based health systems for several reasons. My brother spoke of integration. Faith-based actors had two key functions of the health system: service provision and human resource development and financing. Now, we are seeing from our part of the world where the moment faith-based actors begin to be well integrated into the public health systems, they lose their identity. And the structural environment, regulatory environment within which we operate, for instance, health insurance, Ghana's national health insurance, is making us have mission drift or mission creep, where public health systems are not part, because the financial incentives for sick treatment, disease treatment is there. So you find that our institutions are no longer interested in promoting public health or disease prevention because they don't really provide money. And that is very serious. That is loss of identity, loss of values, loss of interest, and the rest. And so all these are culminating in the fact that we need to have a way of enhancing faith-based systems for them to provide the comprehensive service delivery portfolio, disease prevention, curative, promotive, rehabilitative, palliative, and all the other actors. Extremely important if that is to move on very well. But then when it comes to our institutions, we saw in the COVID-19 pandemic response actions how if the faith-based health systems were strengthened in terms of disease surveillance, laboratory diagnosis systems, workforce development, that would be extremely instrumental. I think there are clear gaps. As far as we know, there would always be significant gaps in public health, government health systems, let me put it that way. And that complementary role, that was to supplement or ensure that the unreached, the vulnerable public are reached, are very important. So my point will be this. Let us see how faith-based health systems should be supported, facilitated, enhanced in terms of health system strengthening, in service provision, in financing, workforce development, and so that our identity, our values will be preserved, protected, and promoted at all points in time. If that is not done, for instance, when I was chair of HAP, I saw that over 50% of health services provided in Africa were by faith-based actors. And yet you find most of the bilaterals and having G2G arrangements with the hope that when you give money to government, it will trickle down to other actors. That is an illusion, because the political economy of health dictates that every 4 years, that's a lifeline of a president. They must invest in visible projects and the rest to treat, for them to have vote and not necessarily promoting health or preventing diseases. I'm saying all this because our capacities, our assets and treasures and the rest are so huge, and yet they are sub-optimized. My point had to be strengthen and invest in faith-based health systems as a way of ensuring pandemic preparedness, prevention, readiness, and response. That would be my intervention. Thanks.
Thank you. And before I ask the last question for the conversation, I want to give just a few informations from in 2022 in April. The G20 finance ministers asked the World Bank to explore setting up a financial mechanism, a financial intermediary fund called the Pandemic Fund, to invest in pandemic preparedness and prevention. And the main goals of the Pandemic Fund is surveillance, laboratory facilities, education of health workers, and community engagement. And at present day, the Pandemic Fund has raised $2 billion. It has awarded $885 million in grants, which mobilized additional financing over $6 billion. It has helped 75 countries strengthen their PPR capacity. And in the third call for proposals that was closed here in June, the envelope was $500 million. And what the Pandemic Fund does, and why this is relevant for faith-based organization, the Pandemic Fund award these grants to governments via 13 implementing entities. And that could be the African Development Bank, the World Bank, the IFC, the Asian Development Bank, and so on, also CEPI and Gavi. But these 13 implementing entities can then work together with delivery partners, which could be faith-based organizations. And that's why I will ask the last question to this panel, and that is, in this changing financial architecture of development aid globally, how do the five of you assess the future role of the faith-based organizations? Because while the state development aid is going down, it could be US aid, the British government, and so on, the faith-based organizations still have the same amount of money. So can the faith-based organizations play a bigger role in this financial setup that we know, also as delivery partners with the implementing entities, for example, for the pandemic fund?
Yes, very
Good.
possible.
Thank you. Then
Yes, very possible. But I have an example to give that would
Yeah.
complement, I'll provide a template. The issue had to do with equitable resource allocation and appropriate funding formula, allocation formula. Now, during the COVID-19 pandemic, the British government, UK Aid, realized, assessed, did some scanning and scoping within our environment and saw the risk and potential of investing directly either in government or giving it directly to child Christian faith-based actors. And this is what they did. They gave £3 million to CHAG as fund holding agency, where government, Ghana Health Service, had to take some from CHAG under some strict accounting scrutiny. And this is what happened. We ensured effective response, testing, surveillance, workforce development, risk communication. Post-COVID, not to self-praise, we were assessed as the most accountable recipient of UK aid funding. I guess that is a template, because if you want faith-based actors to complement and play a significant role in pandemic prevention, preparedness, readiness, and response, I think there should be some funding allocation from line the rest, because one, that stewardship, that sense of ownership is very clear. And so there should be a rethink, a paradigm about the assumption that once global entities give money to government, it will trickle down. We have a clear example that it wouldn't work tomorrow. It sounds nice for diplomacy, but the reality is what the UK aid has demonstrated. And in my part of the world, we've told partners, if you want us to play that role that you want us to play, please have rearrangements of the funding formula so that we'll do so. And no wonder our current president, when he assumed office, did some scoping. It is on the internet. Described CHAG as the most efficient, effective, and accountable service provider. And that is a validation. So that is a template that we can replicate so that that funding formula will ensure equitable resource allocation, a transparent, accountable manner, in a way that will also be able to provide inclusive, equitable access to public health services to the needy, unreached, and the marginalized segment of the society. Well, thanks.
Thank you.
Yeah, hi. I'll be brief. I think we're running out of time. Traditionally, there are three entities that deliver services in countries. Traditionally, now there could be more than that. But the ones that play a significant role is government, it's the faith sector, and the private sector. In global health, unfortunately, what has happened over the last several decades, we've also created a lot of other intermediaries, mostly international NGOs and local NGOs. And they have tended to bypass some of those traditional mechanisms and have actually weakened them. I mean, in environments like this, we have to tell the truth. Because what you've done, they've built parallel systems. And those parallel systems have siphoned technical resources, especially human resources, from those other institutions into this new intermediary that was created. Now, it wasn't routing for USAID to disappear, but now that it's mostly gone, we have an opportunity to rethink how we want to provide support to these different sectors so that they can play a more effective role in pandemic preparedness and response. Now, for the faith sector, there is also this other misunderstanding sometimes that when you create a mechanism for civil society, that the faith sector will benefit from that. I think the two should be differentiated. The faith sector, yes, some characteristics they share with civil society, but they're different. And so for the Pandemic Preparedness Fund, I would urge that we think of a window that addresses the faith sector, and we provide them resources to build the infrastructure and the systems that will complement the public sector in strengthening pandemic preparedness, response, prevention, whatever you want to call it, systems. And part of that money should be used to do some, what I would consider cross-cutting investments, because there are specific weaknesses within the faith healthcare systems. The government side has at least the Ministry of Health that tries to build like a data information system that cuts across all their hospitals and clinics. The faith side doesn't necessarily have that. So, and for pandemic preparedness, you need effective surveillance. And you can't do that if you have got a weak data platform. So there is a need to invest in some core infrastructure that they haven't done over the last several decades, including in good governance, leadership, and management, so that people will understand if you have a hospital that belongs, say, to my faith, the Catholics, that there should be a governance structure that is not necessarily just controlled by one bishop, okay? But it's a governance structure that ensures oversight and accountability and equip them with these skills to be able to do that. And then thirdly, even when you have faith institutions that, say, belong to the Islamic faith or the Anglican or the Catholics, they have these medical bureaus that you would think they actually control them. They really don't. So there is a need to think of how you can invest in organizing these institutions to be better integrated so they can achieve economies of scale and become viable enterprises. Now, there is a concern about, do they lose their mission? No, they don't. You can't fulfill that mission of serving the poor and the vulnerable if financially you're not viable, for example. And we've seen it. They're beginning to ask for exorbitant fees from the poor, and that's why they've also gone on to accept all types of money for things. So we need to strengthen that system, those institutions, in order for them to then contribute to the ecosystem around building resiliency in countries for effective preparedness, prevention, and response, plus rebuilding. Thank you.
I will give the floor to Douglas, and then you have 1 minute, and then we will listen to you, Jeffrey, for 1 minute. And because they have cut our time, you won't be able to ask questions in the audience. But I'll give you 1 minute each, and then we will finalize. So, Douglas. It's
not a level playing field right now. So right now, yes, faith-based should be at the table. They should be able to get something out of these funds. But right now, governments are also scrambling to cover their costs. Yeah. And so they're boxing out faith-based right now, even for access to pandemic fund. That's for within government. That's also for the regional entities. So that's a challenge that we're hearing. So hopefully we can address that. By the way, private investors are taking interest because faith-based communities have a longer shelf life than INGOs that they previously had been investing in or partnering with. So it's very interesting to see a changing dynamic right now.
Yeah. Let me finish with some spice and disagree with a couple of our panelists. First, what's the faith sector? A faith-based hospital or clinic, the groups that you represent, Peter, that's a hugely important set of actors in Ghana. But faith communities are much more than faith-based hospitals or faith-based clinics. To have an envelope for faith-based institutions is to imply that there's a faith-based sector. There are many faith-based sectors. They play all sorts of roles. I also think that if we're talking about investment of public funds, whether those are domestic or the shrinking pot of international development assistance or philanthropic funds, it's incumbent on people who are stewards of taxpayer funds to not discriminate against faith-based institutions, absolutely, but to look at where the money will make the most difference. And PPR cannot only rely on medical service providers. We've been talking all along about the importance of multiple interventions, of care, of health promotion and other things. There's got to be a lot of different actors. So I think, yes, we have to have faith actors at the table, have to have them shaping the strategy and as partners in implementation. But to discriminate in favor of faith-based actors, I would say absolutely not.
And that will be the last comment in this conversation. Please give a warm round of applause to our 5 excellent panelists. Thank you, everyone. And with this, we are done for today, but I don't know if you want to say something before we leave the room.
Just say we welcome you to come back at 9 a.m. tomorrow.
Thank you. Have a good evening, everyone, and thank you for now.
I know.